Again, Mr. Barr, I recognize you for 5 minutes.
Thank you, Madam Chairwoman. My grandfather served on a destroyer in the Navy in World War II, and he was diagnosed with cancer as a young veteran, and he received treatment and was in remission. And then at age 59, he was diagnosed with multiple myeloma and passed. This was in 1977 when I was a young child. And of course, we've had a lot of advances in diagnosis of cancer and treatment of cancer, and obviously service members in eras since World War II have better treatment outcomes and hopefully better diagnostics. But we think that my grandfather was exposed to radiation on that destroyer. We don't know for sure, but we think that was probably what caused his cancer. In Vietnam, obviously, Agent Orange is something that we think is a cause, and then now in the post-9/11 generation burn pits, but radiation throughout the eras. My question to you all is, what advances in precision medicine are helping with diagnosis, and how is the VA doing in terms of, in conjunction with DOD, how are they doing in terms of, identifying risk factors for cancers with service members, and how is the VA trying to detect these cancers earlier because of service members' exposures to these various risks? And I'll start with Dr. Clancy.
Sure, and I'll start off and then turn to Dr. Ramoni. So at baseline, as a foundational element, of course, veterans receive the current state of the science recommended screening tests for cancers, which sounds fairly basic, but it's surprising because not all Americans do for one reason or another. So that's colorectal cancer screening, breast cancer, and lung cancer, and so forth, all of which is good stuff. Linking that back to exposures as a result of service is trickier for sure. A lot of our ability to do that is obviously dependent on the precision of the records of where people served. Now, depending on their job classification, those records may be more available or not. But that's why it's very important that we have a research collaboration as part of our Health Executive Committee, where VA and DOD come together on a regular basis to explore those very issues. For some conflicts, the first Gulf War is a good example. There's very, very little information about where people served because of the short-term nature of the deployment, and we just don't have very good information. For other issues, it's a matter of our records available and so forth. But obviously, as you pointed out, with burn pit exposure, people are very, very worried about that, which is why we're trying to beef up the registry and encourage people to come in for exams and so forth. Do you want to add?
Dr. Ramoni?
Surely. So first of all, I would agree with Dr. Clancy that getting accurate records of exposures is key to our ability to understand the impacts of those exposures. There are well-known associations with Agent Orange and cancer, and prostate cancer have more severe cancer if you're exposed to Agent Orange. Camp Lejeune exposures, but for the multiplicity of things people were exposed to in their deployments to Iraq and Afghanistan, we need to understand much more, and we are committing to, we're in the process of putting together 2021 priorities, and we are committing to better understand the effects of military exposures. And in particular, there's a dearth of information on the clinical side. So we have a lot of epidemiologic research, we have basic science research, but there's an enormous gap for the clinical research that will lead to translation much more quickly.
Thank you. And in my remaining time, of course, with precision medicine, there's a tremendous opportunity. And what we're told is that in oncology in particular, there's potential with the use of molecular diagnostics at the time of diagnosis to help establish genetic characteristics of cancer. Is the VA performing this type of molecular testing for cancer patients at the moment of diagnosis? Yes. And what is the promise of that? Explain that to us.
So it's unknown what the promise is right at this moment. There are some diagnostics that are well recognized. For example, there are certain types of lung tumor variants that have turned out to be very important, and we're working actively with several organizations that are facilitating access to industry funding for additional research in this area, which is terrific. At the moment, for lung cancer, those appear to be a small minority of patients, although it's amazing to meet people who tell you they were diagnosed with stage 4 lung cancer 7, 8 years ago, and, you know, here they are just doing fine now, which still blows my mind. For other areas, we're still in a much more exploratory phase, so I'm thinking about relatives who have shared their results of testing with me. When I say to them, gosh, this is like a lot of markers and tests, and did you ask what they're for? And they all said, well, yes, but, you know, they're not sure yet, but they're testing just in case. And we haven't quite advanced to that level yet, but the number of tests that are actually approved and recommended in terms of the evidence that we've got that it makes a difference is still a fairly short list. We do have a partnership with the Sanford Health System, actually looking at a cancer survivorship cohort, which may have helped the situation you described with your grandfather, but that was just launched about a year ago. So we'll have more to report on that as it progresses.
Thank you. I yield back.